Welcome to the Blue Room with Nisa. I'm Nisa. Welcome back to my page. I'm so glad that you guys are here. It's been a few weeks since I've posted. I kind of told some emotional stuff about my faith journey, my conversion story, and it's very emotional, very personal, and um, needed a minute to kind of like regroup after that and figure out what I really wanted to talk about on this page. And it's going to be mostly my stories, but also um, some faith based. But I am certainly not a theologian or a scripture scholar. I don't represent the Diocese of Lansing. I don't represent my local parish. I am not speaking for the Catholic Church on a whole. What I'll talk about is things that have happened to me, things that I have seen and done, both prior to my conversion and then after as a Catholic, and then also my nursing experience. I've been a nurse for about 20 years. I've done ER work. I've been a hospice nurse. I've been in leadership both in short-term and long-term care, and also leadership in hospice. And now I am a nursing instructor. I teach nursing students both on campus and at the hospital. So I have the benefit of having experienced a lot of different patient types and seeing a lot of different patient experiences. And there's a huge change in how I was as a nurse when I was a brand new nurse, as how versus how I am now as a nurse. And a lot of that, of course, is maturity and time and experience. But I think that the most notable change is my faith, how I see people in the world and how I treat people in the world, especially when I'm a nurse or I'm acting as a nurse instructor, is much different than how it was 10 years ago, 15 years ago. My faith has really shaped my view of the world. And as a result of that, I think that my patients benefit from that. So today, my thought was, because that first video that I did, that I talked about hospice and how I had like proof of life after death because of the hospice patient having a conversation with somebody that I couldn't see. There was a lot of positive responses to that, but then most recently on other social media platforms, I engaged in a conversation with somebody that was equating Roe versus Wade to hospice nurses and how they kill people with morphine. And my heart was sad for this person because losing a loved one is really hard. And then when there are things going on in the home, like with hospice care, because hospice is done in the home most often, that the family doesn't maybe understand, or treatments or processes weren't explained well. I feel so bad for these families because then they're left with not only the process of grieving and all of that loss, but then the misconception or misunderstanding or wrong perception of what the process is really like. So I thought today that we would talk rather than about morphine and pain meds and that type of thing, because that's kind of like inside nursing baseball a little bit. I'm happy to address that stuff. But really today what I wanted to talk about was like tube feedings. So a tube feeding is an artificial opening that goes into the patient's abdomen. This is where nutrition, hydration, and even medication can go through. And this is for patients who can no longer effectively swallow. And I often got asked the question, mom's not eating or drinking anymore. Should we start her on a tube feeding? Well, this was a hospice patient. Mom was minimally responsive and didn't have an effective swallow. Patients at the end of life, they don't need the caloric intake that you and I do on a day-to-day basis. This seems to be one of the hardest things families have to kind of cipher through, navigate, and figure out. And again, it's heartbreaking because it's such a guttural feeling for these families. I don't want mom to starve to death, and I don't want her to dehydrate. And as a nurse, I 100% agree. But there comes a point where at the end of life, in the last week to days, the human body is going through a lot of changes. There's also a lot of spiritual and mental work going on, and this is pretty internalized to the patient. Sometimes they'll verbalize, like the patient I spoke about in a previous video where he actually was talking through some of this stuff with his brother-in-law. But a lot of times it's quiet time. So I normally in those points at the end of life, when we're seeing clear and defined signs that the patient is transitioning from being terminally ill to an active dying state, that to one, put the patient through a procedure like that is painful and unfair, and two, his or her body just doesn't require the calories, and that the work it takes for the human body to process those nutrients and expel them naturally is such a physical burden that it can actually cause increased pain and discomfort, increased restlessness, and it takes the attention away from what the body is doing physically, mentally, and spiritually to prepare for this final journey. That now all of the focus becomes on, I have things inside of me, nutrients in bulk, that I need to expel. And muscle tone changes and nerve and sensory and all of those changes go into play to where they can't expel the nutrients and it becomes uncomfortable and burdensome. So I often try to educate families, explain to them you're not starving mom to death. She just doesn't have the need for it. Now, I enjoy food, obviously. The cheeks are evidence of that. But the human body, when it's lacking something, it craves something. So if somebody is needing nutrients, they're going to be hungry. Now, that's not to say that tastes don't change. COVID's a great example of this. You know, many people with COVID lost their sense of smell and taste, and it became then a challenge to find things that weren't offensive to eat and drink. Hospice patients or end-of-life patients actually go through something similar, and it's not because they have an infection or something is wrong. It's part of the process that things and messages from mouth to brain are changing. So they may not enjoy their favorite food anymore. It may need to be something, you know, with a stronger taste that they can actually taste, like more sweet, more sour, more spice sometimes. Or it may be they're not feeling hungry, but they're eating because it's what we do at lunchtime. It's what we do at dinner time. The bigger concern as a family member to a hospice patient should be encouraging and offering plenty of fluids. Now, that doesn't mean forcing it. We never force patients to eat or drink because they know what their bodies need. Even if they've been suffering dementia for 20 years and they no longer recognize you and aren't making words that you understand or making words at all. Our body is, well, you know, God's a brilliant engineer. He designed us to know what we need. And to be able to recognize. And in those moments, as that transition is happening, those hospice patients become acutely aware of what's going on with their body. They may not outwardly show that they like or don't like something or that they want something, but forcing someone to eat or drink not only it is unkind, it also puts the patient at an incredibly high risk for aspiration. Aspiration is when you, rather than swallow something into your stomach, you and it goes into your lungs. That's what we would call like a choking episode, but patients can slowly aspirate to where you don't notice that they're choking. It's just they don't have an effective swallow any longer. So the liquids or whatever you're putting in their mouth have a risk of going into the lungs. The lungs don't like new visitors coming to their house. So then we're looking at shortness of breath, cough, infection, ineffective airway exchange. I mean, it's just a whole host of problems. So we never force food or drink on a patient. Now, if a patient already has a tube feeding, we don't remove that in hospice. We may discontinue using it. And that's when there's evidence that putting things in it is now a burden or a source of pain and discomfort. Hospice, unfortunately, a lot of physicians aren't really good at having the hospice conversation, and they call hospice in much too late. You can be on hospice for a prolonged period of time. Hospice should not be the last 72 hours of someone's life, because you don't get a chance, for one, the nursing staff to really get to know the patient and get to know you as a family. But so many opportunities of symptom management and pain management have been missed at this point that that's oftentimes where that perception of, sure, we called it hospice, they gave mom morphine and she died 2 days later. She was going to die 2 days later regardless. All that morphine did was perhaps give her a few moments comfort. The type of morphine normally used in hospice is a liquid that can go in the cheek or under the tongue. It is fast acting because it's absorbed through the mucous membranes, and it's not long acting. So if you have a patient or a family member who's having marked decline and decreased function, it's okay to ask your doctor, is my mom or is my dad hospice appropriate? Like, should I be thinking about long-term symptom management and cure rather than curative type of thing? There's also other misconceptions about, well, if mom falls, I want her to be able to go to the ER. Well, of course, if lacerations hurt, broken bones hurt, urinary tract infections hurt, respiratory infections hurt, all of those things can be treated. It's just to what extent, and then you're juggling the risk versus benefit, and that is a decision between the provider and the family, or the patient if they're still a walking, talking, or an up and talking patient where they're still decisional. But families struggle with we're no longer using the feeding tube. So there is, if you look in the Catechism of the Catholic Church, it describes ordinary and extraordinary interventions to keep someone alive. You dance a very fine line with the extraordinary and ordinary when it comes to a feeding tube, especially at the end of life. Now, I'm not talking about like Terry Schiavo when her feeding tube was initially placed, because it wasn't a burden to her body. She was still able to process intake and have output, so it wasn't taxing and it wasn't detrimental to her. That's why the case was so big in the news. Plus all of the drama, right, that went with it. But there weren't clear and defined signs that she had had a marked decline or a marked change to where those nutrients and that hydration was an actual physical burden for her body to manage. And I think that's where the conflict went. It was very heartbreaking. So putting one in is a big decision because, again, of the Schiavo thing. Having someone remove it when it's not appropriate to remove it, or having someone putting things in it when it's not appropriate to use anymore. This is where physicians and families need to have hospice conversations much earlier in the disease process, regardless of what the disease is. So if, say, mom has dementia, and you can see that she's really declining and not able to perform her ADLs. Those are activities of daily living. So she can't get herself on and off the toilet. She can't clean herself appropriately. Can't really brush her hair or get dressed any longer. Those are key moments to have conversations with your mom's doctor about, what do I expect coming down the line, and is hospice appropriate at this point? And there are some very specific criteria about whether a patient qualifies for the hospice benefit or not. It's not unusual for patients to come on early and then plateau. We call it the hospice honeymoon because, we get symptoms managed and do some education in the home, some techniques that kind of help navigate the normal day-to-day. And we find that rather than the steady decline that you'll see in a patient, they start to plateau out, right? And they're just kind of riding that hospice honeymoon. And so to remain on hospice, you have to have a continued decline, a measurable decline. And that's where the challenge is, because families, especially families who are primary caregivers and taking care of that loved one, they'll see those fine nuances and notice that, hey, that's a big change for mom, because you knew mom before, you knew mom during, and now you're seeing something new. For a hospice nurse and the hospice staff, we need to see something that we can measure. So things like weight loss, decreased oral intake. There's a multitude of things. Anyways, so having those conversations with the doctor and then getting on hospice, and say it is too early, then you graduate from hospice, and that's never a bad thing. That hospice benefit is still available to the patient again, if 6 months down the road they're now having more decline. It's heartbreaking to see as a nurse when you go into a home and you can see that the patient's already transitioning and they're in an active phase of dying, and this is your first meeting with them. And rather having those conversations about, this is what hospice can do, and these are all of the benefits, and there are many benefits to hospice. I would strongly encourage any family who's struggling with significant decline in a loved one to really reach out and investigate the benefits of hospice. But when you're in that like last 72-hour mark, it's really now about, how can I avoid the ugly parts that sometimes happen with death for this family? Make the patient comfortable and make this a decent experience for the family, because it's already hard. You're losing somebody that you love. But where that pain and the symptoms and the issues and the challenges have all been going on for so long with no interventions, it's very hard to come in at the 11th hour and like make things beautiful and comfortable. There is such a thing as a beautiful death, and I know that there are people out there that are going to go, oh, death is awful, I'm so afraid to die. And that's where the Catholic in me kicks in, because I'm pretty okay with it. Like, I'm not wanting to end my life or anything crazy like that, but you know, when it's my time, it's my time. And I'm good with it, because I have hope for the future. Anyway, but there is a beautiful death, and, you know, families will often want to, like, oh, mom is hurting so much, just knock her out. We don't sedate patients very often for pain management, because hospice is about quality of life, not quantity of life. So as a viewer, if you have questions about your experience with hospice care for a loved one, or just hospice in general, or what the church, do I have to be a DNR because I'm Catholic? Heck no. Do I have to be willing to go on a vent if I've had a stroke and things happen? Also no. So, you know, if you want to post a question, I'm happy to answer it. If you're not comfortable with that, I would say talk to your priest about what the church teaches about end-of-life care. These are important topics to talk about when you're younger. And younger is relative, because I'm always surprised every morning when I wake up and I see the 50-year-old face, because I'm expecting the 18-year-old face. But it's important that your loved ones, whether it's your spouse or your children or your nieces, nephews, cousins, whoever's going to hopefully be around for you at that time, that they know your wishes. You can map out what you want your end-of-life care to look like. Like, if you don't ever want to be put on a vent to breathe for you, you can specify that. If you're willing to continue to go to the hospital, but only for IV antibiotics and emergencies, you can specify that. If you want the works done, move heaven and earth, and every attempt be made, you can make that known. But it's important that your family knows what your wishes are, because when a hospice nurse like me comes in, that's one of the first things I ask. What did mom want? What did she want this to look like? You know, I've had patients in the hospital, their dying wish is to die at home. You know what? I am going to do everything in my power to get you home so that we can do that. There's also patients who are like, I want to be home as long as I can, but when I start to transition, I don't want to die in this house. I don't want my wife to have to remember this is the room I died in. I get it. That's your wish. And again, do everything in my effort to try to anticipate those moments when we need to make that decision. So have the conversation, talk to your doctor, talk to your priest, talk to your families about what you want. But just know, hospice doesn't end your life. Hospice tries to offer you the opportunity for some quality time at the end of life. The church doesn't dictate whether you're a full code or a DNR, or if you get a tube feeding, or if you're on a vent. It does outline pretty specifically, though, there is to be no assisted suicide, whether it's physician assisted or family assisted. We don't do that as Catholics. And honestly, as a hospice nurse, I would be hard pressed to help facilitate or participate that. And I know in some states, hospice assists with it. That's no, thank you very much. I'm looking forward to purgatory and heaven. So I know this was kind of a little bit scattered, but I hope I answered some questions that you have. And again, to the person who posted on Facebook that hospice and morphine is just like Roe versus Wade. One, no, it's not. First and foremost, nurses don't use morphine to kill people. That's not the benefit of morphine, and is it possible? Sure, in large doses, and I mean super large doses. But quite honestly, if a nurse wanted to go on a spree, there are more effective ways to do it. And secondly, Roe versus Wade ends life before that young person has a voice. And that young person is truly, in fact, a person. I'm very excited about these heartbeat bills. I love that the Knights of Columbus, especially here in Michigan, have that mobile ultrasound thing, so it gives women an opportunity to see little arms, little legs, little hearts beating, and I mean, it's an amazing thing. The two, hospice and Roe versus Wade, are so entirely not related, and I mean, they're not even like third cousins to each other, other than they fall under the umbrella of we don't kill people from the womb to the tomb. No bueno. Not doing that. Not good. If you have other questions about the consistent life ethic, because it does address assisted suicide and just war and capital punishment and of course abortion, I'm open to doing those as topics. But again, I do appreciate you guys coming to this page. If there's more things you want to know, or things you agree with or disagree with, I mean, I'm sure at some point I'm going to get hate comments, and I've got thick skin, I'm good for that. So I ask you to subscribe, because that lets me know that I'm actually like hitting people with this, and not just entertaining my own little fancy. If you can hit the like button, that would be fantastic as well. And again, I look for the comments. I will respond to probably all of them. And this is Nisa from the Blue Room. So, toodaloo, and I'll see you all next time.